Greetings. Let us learn about endoscopic management of variceal bleeding in a patient with cirrhosis. These are my acknowledgements and a notice to review. So, when you see a patient with alcoholic cirrhosis, or for that matter, any type of cirrhosis, when they present with hematemesis, you should consider that the most likely cause of bleeding in that patient is from the varices. In addition to assessing the hemodynamic status and taking the precautions to protect the airway and considering resuscitation of the circulation, you should also quickly figure out the child's Torcott fugue class of the patient. By looking at whether the patient is encephalopathic or not, whether the patient has ascites, whether it is mild, moderate, or severe, and looking at the bilirubin level and also prolongation of prothrombin above the normal value. You try to assess whether the patient belongs to child's A class with 5 to 6 points, child's B class 7 to 9 points, and child's C class 10 to 15 points. And assessing the child's class is very important in the management of variceal bleeding. And we will come to that at a later stage. So, as soon as you see a patient with suspected variceal bleeding in the setting of cirrhosis, there are a few basic things you want to consider. First, protect the airway, and then start medical therapy, vasoactive therapy with octreotide, antibiotic prophylaxis with ceftriaxone, and transfusion using the restricted transfusion protocol to a hemoglobin of 7 and avoiding overloading the circulatory status by avoiding transfusion of FFP, cryoprecipitate, and platelets. These are basic medical management principles when you see any patient with cirrhosis when they hit the emergency room to have a good outcome. And once the patient is stabilized, within the first 12 hours, you should refer the patient for endoscopy. When it comes to endoscopy, it is also very important to keep in mind the fact that you should avoid the risk of aspiration. And if the patient is at risk for aspiration because of altered sensorium or with active bleeding or vomiting, make sure you protect the airway by having the patient intubated, that is endotracheal intubation, before you perform endoscopy. If you think that you can suction the blood and get away, you are mistaken. The amount of blood that can pour out and get into the lungs, for which you can't do much, the risk is too much. So make sure you protect the airway. And when you do an endoscopy in a patient with cirrhosis, you have to think about the various causes for bleeding or causes for hematemesis in a patient with cirrhosis. As you enter the esophagus, think about esophageal varices, as you see here. And then when you go into the stomach and retroflex, look for fundic varices, as you can see here. And as you move towards the pylorus, you may see gastric antrovascular ectasia. In addition, patient may have a non-portal hypertensive reason for bleeding, like a peptic ulcer bleeding. So these are all the things you should evaluate every patient that you perform an endoscopy, especially when they come in with hematemesis. So let us think that this patient came in with esophageal variceal bleeding. So you have done the EGD, you did not find fundic varices, there's no gastric antral vascular ectasia, there's no other ulcer in the stomach or duodenum. What do you do when you come back into the esophagus? How do you manage the esophageal varices? So here is the anatomy I want you to look at. You have uh, periesophageal veins, and from there, perforator veins feed the submucosal and mucosal plexuses of veins. Notice that the number of perforator veins are high in number, especially close to the GE junction. And that is important because if you want to prevent the varices from forming after you have performed endoscopic band ligation, you should start your banding very close to the GE junction, keeping in mind the perforators are maximum in density and feeding the GE junction. That's a very important principle in endoscopic band ligation. So, coming back, when you do the endoscopy, look at whether the varices are large or not. Varices that are more than 5 millimeters are grade 3 varices. Grade 3 varices are kissing each other, large and almost occluding the lumen. Those are the varices that are high risk for bleeding. And if the varices have red marks on them, either spots, what we know as hematocystic spots, or linear signs, these are red whale signs. Again, these indicate that the pressure in the veins is high, and these red marks indicate enlarged vessels in just adjacent to the epithelium, and these are likely to rupture. So when you have a patient who has come in with bleeding and has large varices, and they usually have these red whale signs, you set up for endoscopic variceal band ligation. And where do you start the banding? You start the banding close to the G junction where you have the maximum perforators. So once you put bands here, you are likely to cut down the risk of reformation of varices. At the beginning, in the first attempt, you try to put anywhere between 4 to 6 bands. In some patients, depending upon the variceal burden, people may go a little higher in terms of band ligation. So at least 4 to 6 bands is what we normally do to control the bleeding, starting close to the G junction and moving up. And focusing your bands very close to the G junction and within the first 5 centimeters above the G junction. So you perform the band ligation, and for some reason, despite the band ligation, your bleeding, the patient's bleeding is not controlled. In that case, you may want to either consider putting a stent or putting a zinc stick in tube and request the intervention radiologist to consider putting a transjugular intrahepatic portosystemic shunt. So what does this one do? Putting the shunt between the hepatic vein to the portal vein. As you know, the pressure in the veins in the varices is high, and once you place the stent, the varices get decompressed with the flow from the portal vein, bypassing the resistance in the sinusoids directly into the hepatic vein and up into the IVC. So putting a tips or the shunt inside the liver between the hepatic vein and portal vein will result in a drop in the variceal pressure and control of bleeding. On the other hand, if you are successful in controlling the bleeding, what do you do next? So we talked about the importance of assessing the child's class of a particular patient. Chi- Child's class A is, you could say, a relatively well compensated liver disease. Child's B and C, as it goes with higher points, there is much more decompensation of the liver, and child C patients tend to do poorly. So, so we have figured out the child's class at the beginning when the patient hit the ICU, and here is a patient where band ligation controlled the variceal bleeding, and this is a relatively uh, early stage of child's A or early B of 7 score. In that case, what you do is you continue the supportive therapy. We have started the octreotide. We continue the octreotide for anywhere between 3 to 5 days. We continue the intravenous ceftriaxone, and if the patient does well, you could restart oral intake. And then once the patient starts oral intake, it's a good idea to start them on a non-selective beta blocker. We have three options: carvedilol, nadolol, and propranolol. Among the three, carvedilol is preferred because it has a better effect on the portal pressure and outcomes are much better than compared to the other beta blockers. And you don't need to worry about monitoring their heart rate. And then you consider scheduling the patient for repeat banding in 6 weeks. Once you put once you put bands, they will slough off and form ulcers. Starting them on a PPI for the next 4 weeks allows those ulcers to heal faster. How about if a patient has a little more advanced disease, that is child's B 8 to 9 or child's C 10 to 3? Child's B 8 to 9 and you noticed active bleeding during the endoscopy, that patient, as well as advanced child's C 10 to 13 score, you continue the supportive therapy, octreotide, antibiotics, restrictive transfusion strategy. But in addition, you also ask your interventional radiologist to evaluate your patient and to see what needs to be done. These patients are likely to do better if you consider a TIPS procedure and reduce the pressure in the portal vein and in the varices. To do that, the IR physician or interventional radiologist will ask for a Doppler to look at the patency of the hepatic vein, portal vein, and make sure there's no liver cancer, and also get a CT scan of the abdomen to get a view of the vasculature so that they could study how to put the stent. And then these patients are taken up for TIPS procedure within the first 24 to 72 hours. This early TIPS has been shown to be beneficial, improve the outcomes in patients where you control the bleeding, but they have child's B status with active bleeding or child C with a score of 10 to 13. On the other hand, if you have a patient who has very advanced child C class, uh, more than 13, 14, 15, 16, that patient needs very intensive supportive therapy. These patients may be very sick. They may be having deep encephalopathy. They may have renal failure. Uh, they're very sick that require intensive supportive therapy. And they have pretty bad liver. And you may you may need to consider a transplant, replacing that badly damaged liver with a new healthy liver. So we talked about how to manage variceal bleeding, medical management consisting of octreotide, antibiotic, restrictive transfusion strategy, avoiding fresh frozen plasma, cryoprecipitate, and platelets, endoscopy within 12 hours, endoscopic variceal banding as the treatment of choice. If you cannot control the bleed, then emergency tips. If you control the bleeding and patient has child's A or early B status, then continue the supportive therapy, discharge them on a non-selective beta blocker, a PPI, and then bring them back for repeat banding within 6 weeks and repeat it until obliteration of the varices. If, on the other hand, the patient has child C or child's B advanced with active bleeding, they need early TIPS procedure within 24 to 72 hours. Lastly, if you have a patient with very advanced liver disease, child C with a score of 13 or more, you should get the transplant team on board for liver transplantation. I hope this is helpful. I want to thank authors of this beautiful review. I hope you could take time to read this, and thank you.